Hi guys, I welcome you all after a long hiatus of almost like a 2.5 months. I'm again starting this series, Mastering Billion Information page by page. And to be very honest, just a sec. I'm very lucky to still continuing this because I had a very worst phase of my life, had a severe pneumonia, got admitted in the ICU, then had a long rehab phase where I lost around 12 kgs. There were a lot of things happening, so couldn't continue that time. But finally, here we are now, and we're going to continue the series as before. I'm Dr. Shailesh Gupta. I'm a laparoscopic, bariatric, and robotic surgeon from Max Perperganj and Vaishali. I'm also the integrative certified robotic surgeon and teaching faculty, conceptual surgery. So I'm a creator of Mastering Billing Solution page by page, in which what I am doing, basically I'm covering this textbook step by step, page by page, so that it gives you a feeling that you're reading the textbook in a very short duration. So what happened? We have got a very hectic schedule, and during which we don't have the time to read this textbook. And the purpose is कि अगर आप रीड कर पाओगे तो ऑब्वियसली आपके कॉन्सेप्ट बहुत ही सॉलिड होंगे और आप कोई भी थ्योरी प्रैक्टिकल एग्जाम या इवन एमसीएच नीट एसएस एग्जाम आराम से क्लियर कर सकते हो एंड आई कैन गारंटी अबाउट यू रीजन बीइंग वी आर covering in this content is a more authentic way. We are not skipping anything, right? So uh, I'm going to cover acalculous biliary disease. This lecture has been made from the Sabiston, and I'm going to cover three topics. Number one, acute calculus cholecystitis. Number two, biliary cyst and polypoid lesion of the gallbladder. The all three are very, very important, can come as a short note, and obviously, lot of MCQs will be asked from this, right? So, as the previous lectures, our flow of the lecture will be I'm going to throw some MCQs, the purpose of which is just to check your awareness. This is not a test. This is कोई आपका कोई यहाँ पे टेस्ट नहीं ले रहा है, बस आपको क्वेश्चन को पढ़ के आपको चेक करना है कि यार आज अगर 10th मार्च है तो मुझे 10th मार्च को एग्जाम से 1 साल 2 साल पहले मुझे कितना आता है। ठीक है, तो ये हमारे ब्रेन को ट्रिगर करता है, ये बताता है कि यार ये क्वेश्चन में मुझे नहीं आता था, तो अभी जब मैं आगे टेक्स्ट को पढ़ूंगी लेक्चर के अंदर तो वहां पे मैं एक्स्ट्रा एम्फसाइज करूंगा या करूंगी। ठीक है, सो फर्स्ट टॉपिक फॉर टुडे इज acute acalculous cholecystitis. So few MCQs. Dr. Alpana, can you read these MCQs for me, please, if you're listening? Yeah.
Good evening.
Good evening.
So first question, sir. Compared to
Yeah.
calculus cholecystitis, acute acalculous cholecystitis is generally more mild, severe, asymptomatic, or same severity, sir.
Right.
And second question, sir, for critically ill patient who cannot tolerate open cholecystectomy, the recommended treatment for acalculous cholecystitis is A. Conservative management with antibiotics. B. Percutaneous gallbladder drainage. C. Endoscopic stenting. D. Lap cholecystectomy.
Right. Great. Thank you, Dr. Alpana, for reading this question for me, please. So, as the name suggests, it is a acute cholecystitis, but it do not have a calculus. So, it is a acalculous cholecystitis. कोई rocket science नहीं, बहुत simple. Acute cholecystitis is the inflammation of the gallbladder without the presence of gallstone. So, what is the pathophysiology that without the gallstone, it is causing the cholecystitis? So, thing is that stones are not present, this is for sure in that, but there is a kind of a stasis. There is a kind of motility disorder in the gallbladder. Because of that, there is a stasis, and this leads to concentration of the biliary solute, and this leads to inflammation of the gallbladder. So, this is a kind of a broad pathophysiology. Exact pathophysiology is still not completely understood. Okay, Dr. Ritu. So main here is what is happening here. So there is a stasis, there is a motility issue. So because of the motility issues, the biliary solute get concentrated, and this leads to acalculous cholecystitis. And the risk factors are what in which patient you are more prone to have this disease. That is older age, critical illness like sepsis. That is why we see that patient in the ICU are very prone to get acute calculous cholecystitis. Second is burn and trauma, prolonged use of TPN. So, Dr. Ritu, can you come on the mic and tell me how TPN cause acute calculous cholecystitis? आप बता सकते हो मुझे? जस्ट अ सिंपल गेस. मेरा अटेम्प्ट ये है कि आई सो मेक द क्लास इंटरैक्टिव, राइट? यस.
सर फैट लेस होता है टीपीएन तो देर इज अ स्टैसिस या फिर कलेक्शन मतलब सिक्रीशंस नहीं निकल पाते तो सीसीके नहीं रिलीज होता बेसिकली मोर शायद.
यस, यू आर एब्सोल्युटली राइट. जो आपने आखिरी में बोला ना, देखो, टीपीएन, यू आर राइट, टीपीएन causes cholestasis, number one. So what is happening in the TPN, Dr. Utpana, Dr. Ritu? So nutrients are directly going into our blood, right? So gut is not used. If gut is not used, CCK is not being released. CCK release, what the CCK do? CCK do the gallbladder contraction. So because of the loss of CCK, there is there is a lack of contraction, and because of lack of contraction, there is stasis, and because of stasis, there is acute cholecystitis. Okay, same in diabetes. Diabetes के अंदर भी there is some kind of a neuropathy which leads to a contracted gallbladder and immunosuppression. So these are the condition in which patient are more prone to develop acute acalculous cholecystitis, right? So clinical course, this is guys, this is very important slide, both of you. Just remember that acute calculous cholecystitis is much more severe, much more rapid than calculous cholecystitis. ठीक है, ये हमें याद रखना है, ये बहुत इंपॉर्टेंट है. That is why you need to be more cautious with these patients. Okay, so guys, reading with standard textbook give you clinical skills also. This is not all about passing the exams. It gives you concept, right? So increase this complication like gangrene and perforation with acalculous cholecystitis than the calculous cholecystitis, right? What is the clinical significance of this? So you need to early recognize and you need to be very aggressive in management of these condition in critically ill patient. So otherwise, other symptoms like fever, anorexia, and right upper quadrant pain will be similar to the calculous cholecystitis. And in critical ill patient, patient might be intubated, patient might be on some kind of sedation. So you might not able to elicit the physical examination. So this might make the picture more confusing, guys. Okay. So here, don't rely only on the clinical signs, right? So what will be the imaging finding? As we know that cholecystitis hai, so they will be inflamed gallbladder. Inflamed gallbladder means they will be a thickened gallbladder wall and they will be a pericholecystitic fluid. So HEDAS can assist in diagnosing, but have to have up to 40% false positive, right? So here you can see how beautifully these three arrows suggest there is a thick wall you can see, and you can see that यहाँ पे अगर आप देखोगे, so you can see. Just hold on, I just show you. So look at the just yeah. So look at the thickness of the काफी thick है ये wall ना, काफी thick है ये. And you can see this is eco-free. This is all is eco-free. बिल्कुल black है सारा ये. So this is a sign of acute acalculous cholecystitis, right? So moving on, just hold on. So how will you treat that? So as treatment is same as we know that calculous cholecystitis में हम सर्जरी करते हैं. तो एक कैलकुलस कोलेसिस्टाइटिस के अंदर भी सर्जरी करेंगे. वी गोना डू कोलेसिस्टेक्टमी. Open procedure is often preferred due to severe inflammation and high risk of gangrene. Guys, this is very subjective, but this is what your Sabiston says. Okay. So as per the Sabiston says for acute calculous cholecystitis, cholecystectomy is the operation of the choice, same as calculus. And Sabiston says open chole is preferred because of the severe inflammation and risk of gangrene. Guys, but in a city like Delhi, we practically do in these cases also lap cholecystectomy. But you can always, at this situation, if your examiner asks, you can always say that, Dr. Subhash, Dr. Ritu, and Dr. Alpana, that, sir, usually what the Sabiston say open coli is preferred in acute cholecystitis, But in